part of a team improving survival rates in severe liver injuries and alcohol-related liver failure through innovative treatments. His areas of interest are liver transplant and endohepatology, with a special interest in plasma exchange and its application in liver disease management. He will be talking to us today on the advances in endohepatology.
Thank you. Thank you for the kind introduction. At the outset, I'd like to thank the Department of Medicine for the invitation, and I'd also like to recollect most of the medicine that I learned, which is a backbone of what I practice. I learned it in Department of Medicine, and I'm very grateful. So, going on to my talk, it's about endohepatology. So, it's an evolving field. The outline of my talk, I'll briefly touch upon what is endohepatology and what we do most, what is our bread and butter, what are we doing new, and what else we started doing recently, and what more can we do. So there is no standard definition of what is endohepatology. Basically, it is endoscopic procedures that are being done for patients with liver disease, and it's a rapidly evolving field. So what we do the most, that is what is our bread and butter, is treatment of bleeding esophageal varices and bleeding gastric varices. So as we all know, endoscopic variceal band ligation, which is EVL, and endoscopic sclerotherapy form the two most common treatments that are being done for esophageal varices. And for gastric varices, it is endoscopic direct glue injection or use endoscopic ultrasound and then place a coil and then do a glue injection. I'll be talking about each of these things. When it comes to management of esophageal varices, the debate on whether EVL or EST is settled long back. So it is EVL that is the preferred treatment because it has decreased rebleed and improved survival, proven in multiple RCTs, and the data summarizing with meta-analysis also concludes the same. But we still do ESTs for some special situations. In children who are less than 10 kilos, usually the band that we load will not be suitable for a child because it might not pass through the upper esophageal junction. So there we do ESTs if they come with a variceal bleed. And people who have had recurrent therapy whose lower esophageal mucosa is fibrosed or they have small varices that are bleeding, we still do ESTs. And despite EVL, if they bleed, endoscopic sclerotherapy is a good option. And post EVL, the healing happens and there may be ulcers which bleed. Those also are treated with endoscopic sclerotherapy. So we inject on the bleeding area and around the bleeding area. So this is a video of us doing endoscopic variceal band ligation. So the endoscopist is just entering the posterior pharynx, is trying to pass through the, I'll skip to the part where, so these large varices you're seeing, esophageal varices. So once we focus on the target vessel, we go and usually oppose the cap. So the white thing you see in front is a cap. Oppose it. Once it is opposed, we give a negative suction. And during suction, you'll see there is a readout. That means the varices are inside the cap and then the band is deployed. We repeat this process across all the bleeding varices, and usually there is multiple sessions that are needed to eradicate varices using EVL. Gastric varices, this picture is showing a large gastric varix which had bled. This is a recent patient we had managed. They are a little bit more difficult to manage, and the usual treatment is direct glue injection into the varix using an injection needle endoscopically. The glue that we use is cyanoacrylate glue. So it crystallizes and the bleeding stops, but there is a risk of pulmonary embolism, MI, cerebrovascular accident in about 1% of patients. So what are we doing new? Endoscopic ultrasound guided coil placement and glue injections are coming into practice for bleeding gastric varices, not for esophageal varices, but for bleeding gastric varices. And the use of Danish stent, both of which I'll be speaking in subsequent slides. So, sorry, I think this video is not playing, but this is a US image. Unfortunately, since the video is not playing, I'll try to explain. This is the color uptake shown by the varices, gastric varices. So the scope is at the lower esophagus, and on endoscopic ultrasound, we are able to focus on the gastric varices, and the US needle will come from this end. And once our needle is placed inside the gastric varix, we first place a coil and then inject a glue. The reason to place a coil is the coil will help in keeping the glue in its place. Usually the coil is selected in such a way that it does not get embolized. So does it mean that US coil is the way to go and direct glue injection should be stopped? Maybe not. So this is our own retrospective data that we had analyzed. Uh, so to summarize the study findings, we had looked at early rebleeding, late rebleeding, and overall rebleeding rates, and of course mortality among the direct glue and US glue. We did it before propensity score and after propensity score matching. And as you could see, the outcomes of these patients are not different, whether you do it directly or through US. So what is new? It's actually a relatively new entity. We've started using Danice stent. In short, it might be a uh, substitute for Sensteak Blakemore tube. So it is used when there is refractory bleed despite EVL, or post EVL there is an ulcer which bleeds. This can be done in ICU bedside without fluoroscopy as well. So we place a stent in the lower esophagus, which sort of gives tamponade effect on the lower esophageal varices, and subsequently the patient has to undergo a definitive procedure such as TIPS. These YouTube links are there, which are anybody could access and see how to place and how to remove a Danicella stent. So this is us doing Danicella stent placement in the medical ICU for a patient who had come with massive GI bleed. And we have done an EVL. Promptly 10 days later, he developed a EVL ulcer, and he had lost hemoglobin from 10 to 5, and he was on three vasopressors. So TIPS was possible, but doing TIPS for a patient at that situation was not easy because he's on three vasopressors, is not suitable for shifting under general anesthesia. So what we did is, without fluoro, we did an endoscopy, placed a guide wire in the stomach. Subsequently, we placed this stent into the patient's lower esophagus, and we confirm the position by inflating a balloon. For want of time, I will sort of fast forward the video. So there are standard maneuvers that you have to do to ensure the position, and subsequently the okay, so subsequently the stent is deployed. So once it is deployed, I'm not sure if the images are coming through nicely, but I think this image is seen well. This is a stent that is placed from the lower esophagus into the stomach. So this tamponade effect by this metallic stent, which is fully covered, will give time for us to do a definitive procedure such as TIPS, so that the portal pressures are taken care of. And then subsequently, this is the third picture is showing us trying to remove we can see the stent collapsing and it comes out through the retriever. So what we started doing recently is US guided liver biopsy. It is not an alternative to transjugular liver biopsy because standard indications for percutaneous liver biopsy is what applies for US liver biopsy. So coagulopathy and patients with ascites, which are contraindications for percute biopsy, are contraindications for US biopsy as well. So it is more as an alternate for percute liver biopsy. So what are the pros and cons? So at the outset, I'd like to mention the biopsy yield from both the routes are comparable, and the adverse effect profile is also comparable. But US guided liver biopsy needs expertise, somebody who's well trained in US. The US needle is costly, and it usually requires good sedation or general anesthesia. The cost is more because the US needle and US cost are there. Whereas percute liver biopsy, we're all aware, can be done with routine pre-medication, cost is less. Bedside focus training is enough for us to do. But some patient-related outcomes such as pain may be lesser for US guided liver biopsy is a consensus in the endoscopy uh, talks generally. So US guided portal pressure measurement. So we always use HVPG, which is hepatic venous pressure gradient, as a surrogate to measure the portal pressure, and we use it to predict the amount of portal hypertension. We started measuring the pressure, I mean, not yet in our unit, but certain units have started doing it endoscopically. They puncture the portal portal vein and the hepatic vein and measure the gradient, and which is said to be a more accurate measure of the portal pressure. So we did a porcine model experiment. This is us doing on Yorkshire pigs. This is US. So what is shown is the IVC, and this is the middle hepatic vein, which we are seeing well on US. And we put color and confirm, and that is a needle placed inside the middle hepatic vein. And first, we are measuring the hepatic venous side pressure. Subsequently, we are trying to focus on the portal vein. This is the left branch of portal vein, and the US needle enters the left branch of portal vein. And once the pressure is measured, we could calculate the gradient by subtracting the portal pressure from the hepatic pressure. So what else can be done? So there are some units which are started doing little, I would say, aggressive treatments. So in patients with hepatic encephalopathy, uh, if there is a large shunt and the patient is early child A, we could close the shunt, and that will prevent recurrent hepatic encephalopathy. So they have attempted endoscopic ultrasound guided closure of these shunts, and have got good reports in 7 patients. So this is another such case report where they have tried to do endoscopic ultrasound guided radiofrequency ablation of a hepatocellular carcinoma, which is in the caudate lobe. So caudate lobe is difficult to access by a percute ultrasound because of its proximity to IVC, whereas it is, as you saw in the previous image on US, it is, you could target the caudate lobe separately. So they have done a caudate lobe HCC radiofrequency ablation using endoscopic ultrasound guided needle. So conclusion, so there are a lot of endoscopic options in the horizon, and some things that we are already doing for patients with liver disease. But the most recent techniques have got the least evidence and are costlier and needs much more time to master. So though my topic is endohepatology and endoscopic procedures, we have to choose the correct patient for the correct procedure. It may not be endoscopic as well. We could do percute. We can do via intervention radiology. So most of our patients who are undergoing BRTO tips, we still get the help of our intervention radiology friends. So this is just a primer. So I've not gone into depth of the indication and contraindications of various procedures. Thank you.
Thank you, Dr. Santosh, for taking us through the advances in this evolving field. I would now call upon Dr. John Titus George, our next speaker, who is Assistant Professor in the Department of